Hi, my name is Alyssa, and this is Medisin, where learning is always in style. Today, we will be introducing the pathogenesis of ischemic heart disease. By the end of this video, you will be able to assess for myocardial ischemia with ECG and serum biomarkers, discuss the function of the coronary arteries, differentiate reversible and irreversible ischemia, outline the pathogenesis of atherosclerosis, and describe the use of statin therapy. Before we start, make sure to like, comment, and subscribe. Also, follow our Instagram at MedisinStyle for more content on life as a med student and study review. Okay, let's get started. Let's begin with a general overview of the circulatory system. The heart has three layers: the endocardium, or inner layer lining the lumen, the myocardium, or muscular layer, and the epicardium, or outer layer. The primary function of the heart is to pump blood throughout the body. Blood leaves the heart in the arteries, which branch into capillaries to perfuse the organs, and these capillaries join once again to form veins, which bring the blood back to the heart. The arteries have oxygenated blood. When the arteries branch to form the capillaries, oxygen leaves the blood to supply the organs, and the blood picks up carbon dioxide and waste. The veins return this deoxygenated blood to the heart for it to be pumped to the lungs. The blood that leaves the left ventricle goes through the first and largest artery, which is the aorta. All the major arteries of the body branch off of the aorta to supply their respective organs. The coronary arteries branch off the aorta to supply the myocardium with oxygenated blood via the exterior surface of the heart. This allows the myocardium to continuously contract. Therefore, it is important for our coronary arteries to remain patent or open. Unfortunately, some disease processes close the lumen of the coronary arteries and obstruct blood flow to the myocardium. Without a consistent oxygen supply, the myocardium dies and stops pumping. This is known as a myocardial infarction, or MI, and it is commonly called a heart attack. This is a super important definition, so I'm gonna say it again. A myocardial infarction is myocardial death caused by ischemia, usually secondary to obstruction of the coronary arteries. MIs primarily affect the left ventricle because the myocardium is thicker and more vulnerable to ischemia. Each coronary artery supplies a specific territory of the myocardium. Although there is anatomical variability between these arterial supplies, general rules do apply. On the left, we have an image of the coronary arteries that perfuse the left ventricle. On the right, we have a short axis cross-section of the ventricles from the radiologic perspective. That means the anterior portion of the heart is on top, the left ventricle is on the right. Just imagine you are looking at the heart from the bottom. The left anterior descending, or LAD, coronary artery supplies the anterior and anterior septal aspect of the left ventricle. The left circumflex artery supplies the lateral aspect of the left ventricle, and the right coronary artery supplies the posterior and posterior septal aspect of the left ventricle. The LAD is the most commonly affected artery in myocardial infarctions, contributing to 40 to 50% of cases. When the heart experiences acute ischemia, there are changes to the ECG pattern. There are many ways ischemia may present on ECG. Let's start with a picture of a normal ECG waveform from lead 2. To assess for acute ischemic changes on ECG, we will focus most of our attention to the ST segment and the T wave. The most common acute ischemic changes on ECG are ST segment elevation, ST segment depression, and T wave inversion. If you ever see these changes, your first differential should be ischemia of the heart. The location of the ischemia can also be roughly delineated on a 12-lead ECG. Recall that a 12-lead ECG, by definition, monitors the conduction through the heart from 12 different perspectives. Leads 2, 3, and AVF assess the inferior aspects of the heart. Leads 1, AVL, AVR, V5, and V6 assess the lateral aspects of the heart. Leads V3 and V4 assess the anterior aspects of the heart, and leads V1 and V2 assess the septal regions of the heart. Ischemia can be broken into two broad categories. Reversible ischemia describes myocardial ischemia that has not yet led to myocardial necrosis. The cardiomyocytes are still alive. Irreversible ischemia describes myocardial infarction because the myocardial cells have begun to undergo necrosis, or cellular death. When myocardial cells die, they release distinct proteins in the blood, which can be quantified. These proteins are known as cardiac biomarkers. And the main two that we care about are troponin and creatine kinase, or CKMB. Troponin levels peak about 48 hours after the onset of necrosis and return to baseline 7 to 10 days later. Therefore, they are sensitive for infarcts, but not reinfarcts within the first few days of symptoms. To assess for reinfarcts, we track CKMB, which peaks within 24 hours of necrosis onset and returns to baseline within 48 hours of necrosis onset. So, if CKMB is elevated 5 days after the initial MI, this is probably indicative of a second MI. In summary, reversible ischemia will present with ischemic changes on ECG and negative cardiac biomarkers, while irreversible ischemia will present with ischemic changes on ECG and positive cardiac biomarkers. So what kind of processes obstruct arteries? The main process that we will discuss today is atherosclerosis. Atherosclerosis is a buildup of lipid plaques in the inner walls of the blood vessels, or endothelium. This hardens the wall of the vessels and narrows the diameter of the lumen. If atherosclerosis occurs in the coronary arteries, we call this coronary artery disease, or CAD. Atherosclerosis is a slow process that is fueled by genetic and environmental factors. Let's consider an artery. The first step of atherosclerosis is damage to the endothelium. Damage can be caused by anything, but hypertension is a common cause of injury. In hypertension, the blood is flowing with such great force that the pressure actually injures the blood vessel walls. When this happens, the site of injury is infiltrated by low-density lipoproteins, or LDLs, and reactive oxygen species are made. Reactive oxygen species further damage surrounding cells. Moreover, macrophages infiltrate the area and consume the LDLs. The macrophages die and the remnants remain deposited in the area. This forms a fatty streak. The damaged epithelium around the fatty streak releases platelet-derived growth factor, which recruits the proliferation of smooth muscle cells. These smooth muscle cells secrete compounds like collagen that contribute to the formation of a thick, fibrous cap. The combination of the fibrous cap with the underlying fatty streak is known as an atherosclerotic plaque, or atheroma. Finally, the smooth muscle cells deposit calcium into the plaque, which hardens this plaque. Normally, high-density lipoproteins, or HDLs, absorb excess calcium from tissues, but HDLs are unable to infiltrate the atherosclerotic plaque to successfully remove the calcium. Now we are stuck with a hard plaque on the interior aspect of our artery. This decreases the diameter of the lumen significantly. General risk factors of atherosclerosis include increased age, high-fat diet, obesity, family history, being male, and being a postmenopausal female. You can see now why doctors love to discuss patients' lipid panels. LDLs are known as bad cholesterol because they are part of the early steps of atherosclerosis. Individuals who eat a lot of saturated fats from animal meat, especially red meat, butter, and cheese, are likely to have higher LDLs. Moreover, patients with obesity or a genetic predisposition may also have higher LDLs. If patients struggle to lower their LDL levels with lifestyle modifications alone, then a medication class known as statins can be given. Statins are HMG-CoA reductase inhibitors. Memorize this sentence for your boards. Statins are HMG-CoA reductase inhibitors. They prevent the synthesis of cholesterol in the body. To determine whether a patient should receive a statin to control their cholesterol, you should consider their ASCVD risk score. This is the atherosclerotic cardiovascular disease risk score used to determine a patient's risk for having a cardiovascular event in the next 10 years. Check out the link below for an ASCVD risk score calculator. As mentioned before, atherosclerosis in the coronary arteries is known as coronary artery disease. If the arteries become significantly occluded, different clinical presentations may arise. These may include stable angina, unstable angina, STEMI, and NSTEMI. All four of these, as well as their management and complications, will be discussed in the next video. In summary, today we introduced coronary artery disease, describe the utility of ECG and cardiac biomarkers in the assessment of myocardial infarction, explain the pathogenesis of atherosclerosis, and describe the use of statin therapy. That's it. Stay tuned for a continuation of this topic in our next video. As always, be sure to like, comment, and subscribe. Also, follow our Instagram at Medisin for more content. My name is Alyssa, and this is Medisin, where learning is always in style.